Hello, my name is Karen Jacobson. I'm an assistant professor of medicine at Harvard Medical School and the medical director of the immune effector cell therapy program at the Dana-Farber Cancer Institute in Boston. And I will be talking to you today about who should receive CAR T cell therapy for lymphoma. These are my disclosures. So just an overview of the talk today. In the next 20 minutes, I'll give you an overview of the clinical data from the clinical trials of CAR T cells in lymphomas. We'll then move into some of the real world data post-commercial approval of axi-cel and tisagenlecleucel in aggressive B-cell non-Hodgkin lymphoma and what we've learned from those studies. And that will lead us into a discussion of CAR T-cell eligibility and referral considerations for both commercial products as well as for clinical trials. And then we'll touch, at least at the end, upon prolonged effects of anti-CD19 CAR T-cell therapy. But in my next talk, I spent a lot more time talking about the side effects of this therapy. So there have been 3 pivotal studies of anti-CD19 CAR T-cell products in diffuse large B-cell lymphoma and other aggressive B-cell non-Hodgkin lymphomas. There is a study from Kite Pharmaceuticals called ZUMA-1 that looked at axicabtagene ciloleucel in this group of patients. The Juliet study from Novartis looked at tisagenlecleucel for these patients, and the Juno/Celgene/now BMS TRANSCEND study looked at lysocabtagene maraleucel for this population of patients. And as you can see, each study treated over 100 patients with their anti-CD19 CAR T-cell product. And this is a group of patients that had been relapsed or refractory after multiple lines of therapy. There was no standard of care option, and most experimental options used to treat these patients yielded responses, expected responses in about 20% of patients and complete responses in about 8% of patients. And the median overall survival for this group before CAR T cells was only about 6 months. And as you can see from this study, from these 3 studies, CAR T cells in this group of patients yield significantly better responses compared to previously expected experimental options, up to 50 to 80% for an overall response rate and up to a 40 to 54% overall complete response rate. And many of these responses are durable. So when we look at data at 6 months, we can see that approximately 40% of patients maintain their response out past 6 months. So the ZUMA-1 study and the Juliet study led to the FDA approval of axicabtagene ciloleucel, or axi-cel, and tisagenlecleucel, or T-cell, for the treatment of relapsed and refractory aggressive B-cell non-Hodgkin lymphoma. We have longer follow-up for all 3 of these studies at this point, and the bottom line is that we do see a plateau in the duration of response curves and the progression-free survival curves, usually most markedly after about 3 months, but certainly when patients maintain their response past 6 months, it has very good prognosis for a long-term durable remission. And across all 3 studies, and you can see it in varying arrays here, you can see that about 40% of patients maintain their remission out past 1 to 3 years for the longest follow-up we have on the ZUMA-1 study. Anti-CD19 CAR T-cell therapy has also been used to treat mantle cell lymphoma, and these are results from the ZUMA-2 clinical trial, which looked at a slight deviation from axi-cel. The product is very similar to axi-cel, except that in the manufacturing process, there's one additional step to remove malignant lymphocytes from the product. And this was tested in patients with relapsed and refractory mantle cell after progression following BTK inhibitors. And as you can see, this is a very high-risk population that we know has a very short projected overall survival. And in this population, 93% of patients responded to the single infusion of the product that is known as KTE-X19, and 67% of patients had achieved a complete response to this therapy. And obviously, we need longer follow-up for a disease like mantle cell that has a long natural history, but with the median follow-up on the study being about 12 months, you can see that there is a plateau in this curve with approximately, a little over 55, somewhere between 55 and 60% of patients maintaining their response out past 12 months. We've also recently seen the results of the ZUMA-5 clinical trial, which is the trial of axi-cel or axicabtagene ciloleucel in indolent B-cell non-Hodgkin lymphoma. So this included a cohort of patients with follicular lymphoma, as well as a cohort of patients with marginal zone lymphoma, all in the third line and beyond. This was presented at ASCO in 2020. And you can see here that for all patients, the response rate was 93% with a CR rate of 80%. And in the follicular lymphoma cohort, we can see the response rate was as high as 95% with a complete response rate of 81%. And although the response rate looks lower in marginal zone lymphoma at 81% with a CR rate of 75%, that's largely because 19% of patients were deemed by central radiology review to not have measurable disease at the time of their CAR T-cell infusion, even though the treating physicians felt that there was measurable disease. On the bottom, you can see the duration of response curves for these patients. So the median follow-up for the follicular lymphoma patients, which is in the blue line here, was 15.3 months. And you can see that for patients who had achieved a complete response to therapy, the likelihood of maintaining that complete response at 15.3 months was approximately 80%. These duration of response curves are not mature because very few patients have follow-up out to 20 months for the follicular lymphoma cohort and out past 6 to 9 months for the marginal zone lymphoma cohort. So just as we need in mantle cell lymphoma, we definitely need longer follow-up to understand the durability of response in these patients. So we can't talk about CAR T-cell efficacy without talking about the flip side in terms of toxicity. And so these are the rates of notable toxicity, specifically cytokine release syndrome and neurologic toxicity across these 5 clinical trials. We will discuss this in much more detail in my next talk about toxicity of newer agents. So now we'll shift gears and talk a little bit about what CAR T cells have looked like in the real world post-commercial approval in 2017 and 2018 for the Kite product and the Novartis product, respectively. And so for axi-cel, we have 3 different real-world series that have been reported. One that is pending publication from it's a multi-center retrospective series that we participated in at Dana-Farber. Another that was reported by Loretta Nastapool, and again was a multi-center experience of axi-cel in the real world in the first year of commercial approval. And finally, we'll talk about the 2 CIBMTR database presentations at ASH last year that looked at axi-cel in the real world and tisagenlecleucel in the real world as reported to the CIBMTR. So as you can see, in terms of overall response rate, CR rate, and 6-month CR rate, we're seeing very similar overall response rates and CR rates to what we're seeing both on the ZUMA-1 trial as well as on the Juliet study of axi-cel and tisagenlecleucel, respectively. And we're also, at least on one series, seeing that at 6 months, 40% of patients maintain their response, which is again, what we had seen from the pivotal clinical trials. And this is despite the fact that almost all, a large proportion of these patients are actually would not have been eligible for the clinical trials. So this is expanding the eligible patient population beyond sort of the perfect clinical trial patient. So these are patients that have comorbidities such as poor performance status, low cardiac ejection fraction, impaired renal function, low blood counts. These are more of the patients that you're used to seeing with relapse refractory diffuse large B-cell lymphoma, and reassuringly, we're seeing actually very similar response rates across this broader patient population. And similarly, we're not seeing an increase in toxicity compared to the clinical trials. We're seeing very similar rates of CRS and grade 3 and higher CRS, as well as neurologic toxicity and grade 3 or higher neurologic toxicity. And one thing I would point out is that as time has gone on, perhaps we're actually seeing improvements in some of the toxicity profiles. So the CIBMTR database includes patients that were treated beyond the first year of commercial approval for axi-cel as well as tisagenlecleucel, and we're seeing an improvement in the rates of grade 3 and higher CRS and rates of grade 3 and higher neurologic toxicity compared to what was seen on the clinical trials as time has gone on. And I think as a field, we've become better at managing the toxicity profiles. So this is data from our series looking at outcomes in terms of durability of response, progression-free survival, and overall survival across our cohort of over 100 patients treated with axi-cel in the first year of commercial approval. And these, on the top, you see just the overall duration of response, progression-free survival, and overall survival curves for the population as a whole. But on the bottom, you see it's stratified based on whether the patients were eligible for Zuma 1, which constituted about 40% of patients, versus patients that were ineligible for Zuma 1 in red, which constituted about 60% of patients. And I do think it's notable to see that patients who were ineligible for Zuma 1 for whatever reason, and this included the use of bridging therapy because Zuma 1 did not allow bridging therapy between T-cell collection and T-cell infusion. Regardless of the cause of ineligibility, you can see that there is a statistically significant detriment in duration of response, progression-free survival, and overall survival in the ineligible patient population. I would point out that these patients still do better than expected based on their disease. So if you remember earlier, I said that the patients in this line of therapy with chemotherapy refractory disease, generally their median overall survival is about 6 months. And here we can see the median overall survival had not been reached even for this group of patients who who would not have been eligible for Zuma 1. The U.S. CAR T-cell Lymphoma Consortium also looked at real-world predictors of CAR T-cell outcomes and identified a number of factors that associated with worse outcomes, including an elevated LDH, which may be a surrogate marker for tumor bulk, as well as the use of bridging therapy. When they looked at the use of bridging therapy with respect to other covariates of response, they found that certainly patients who received bridging therapy were more likely to have higher risk disease by a number of different clinical and pathologic criteria. However, when they did multivariable analysis, bridging therapy continued to emerge as a predictive marker of patients who had worse outcomes. And I had alluded to this earlier that we also looked at this in our series that's pending publication. And in the maroon line here, you can see these are patients who were ineligible for Zuma 1 just because they received bridging therapy versus patients who were ineligible for other reasons in black. And across the board, again, you can see a detriment in duration of response, progression-free survival, and overall survival for patients who received for patients who had received bridging therapy. The group, the TRANSCEND study also reported on this. This study allowed bridging therapy at the discretion of the treating investigator. And you can see that what they found was that there was no difference in patients who received bridging therapy versus not receiving bridging therapy with lysocabtagene maraleucel on the TRANSCEND study. But they also looked at, they allowed a broader population to go onto this study with medical comorbidities compared to the other two studies. And when they looked at patients who had any comorbidities versus those who did not. So essentially a Zuma 1 or a Juliet eligible versus ineligible population. They also found that patients who had comorbidities did a little bit worse than patients who had no comorbidities, but again, better than historical controls. So this leads us to who should be referred for commercial CAR T-cell therapy. And I would point out that the FDA label is very broad. It includes relapse and refractory high-grade B-cell lymphoma, diffuse large B-cell lymphoma, primary mediastinal large B-cell lymphoma for axi-cell only, or transformed follicular after 2 or more lines of systemic therapy. It only excludes primary CNS lymphoma. It says nothing about secondary CNS lymphoma, although many of those patients were excluded from the clinical trials. There's no upper age limit within the FDA label, and there's also no evidence that the tumor must demonstrate CD19 positivity. And many patients on the clinical trials, actually in retrospect, when pathology was looked at by central review, were CD19 negative at the time of CAR T-cell infusion, and there was no detriment in response rate or durability of response seen in that population. Our real-world studies do suggest that an expansion beyond the clinical trial criteria does have some impact on efficacy, but these patients still do better than other available options. And so they definitely represent an unmet need where we need newer options and newer products to treat them, but this is still better than anything else we can offer. But we should note that eligibility criteria will certainly be center dependent in terms of how to expand beyond that clinical trial criteria. Bridging therapy and tumor bulk on many series do predict for worse outcomes. So this brings out the importance of referring patients early at the time of relapse when patients have a lower volume of disease and are less likely to need bridging therapy. That may definitely impact their outcomes following CAR T-cell therapy. And then special considerations in terms of eligibility, and again, this will be center dependent, are can the patient wait in terms of tumor burden and or potential for organ function compromise? What is the patient's performance status and how poor can it be in order to tolerate the toxicities from CAR T-cell therapy? We know that neurologic toxicity does carry a risk of bleeding and potentially intracranial bleeding. And so that is an additional special consideration that each center will consider separately. We obviously need to know if patients have the appropriate cardiac, renal, or pulmonary reserve to withstand some of the toxicities that we discussed. We don't know specifically what to do with patients with a prior history or current history of CNS involvement of their lymphoma, but then again, whether a center will treat those patients will be center dependent. And finally, we don't know how a history of autoimmune disease or neurologic conditions previous to CAR T-cell therapy could impact outcomes because those patients were largely excluded from the clinical trials. The most important thing to note is that timing matters, and it's definitely best to refer at the time of relapse before initiating salvage chemotherapy. So these patients can be shuttled into CAR T-cell therapy should they fail to respond to salvage chemotherapy as soon as possible. In terms of clinical trials, there are still ongoing trials in aggressive B-cell lymphomas, including new products in the third line, and these include some of the allogeneic off-the-shelf CAR T-cell products, as well as some of the dual antigen CAR T-cell products, and as well as existing products and new combinations with checkpoint and other immunomodulatory drugs. There are pivotal or confirmatory second-line trials, which are randomized studies of each product versus salvage chemotherapy with or without an autologous stem cell transplant for high-risk patients who are relapsing within 1 year of their upfront chemoimmunotherapy. And then there are also trials of agents to mitigate or prevent toxicity in the commercial setting, and these include trials looking at anakinra, siltuximab, GM-CSF antibodies, as well as defibrotide with commercial CAR T-cell therapy. We discussed some of the early results in indolent B-cell non-Hodgkin lymphomas. There are additional studies looking at these agents in follicular lymphoma and marginal zone lymphoma in the third line and beyond. And these patients may also be eligible for phase 1 studies of some newer products. Similarly, we reviewed the results in mantle cell lymphoma, specifically the phase 2 study of Zuma 2 study of KTEX-19 in the third line and beyond, post-BTK inhibitor therapy, which has fully accrued. There will be an expanded access study while FDA review is pending of the Zuma 2 trial. And again, these patients may be eligible for phase 1 studies. And finally, there are emerging studies of anti-CD30 CAR T-cell therapies in T-cell lymphoma as well as in Hodgkin lymphoma, and multi-center phase 2 studies will be opening soon based on the work that has emerged from Baylor and the University of North Carolina. So it's really important to be aware of trials that are open at local CAR T-cell referral centers, especially so that you can refer a patient in before they've gone through too many lines of therapy. There are some additional post-CAR T-cell therapy management concerns, especially as patients go back into the community and are followed locally. So initially, after patients leave the hospital, they need to remain within 2 hours of the treating center for 4 weeks from the time of their infusion, and they must abstain from driving for 8 weeks following the time of their CAR T-cell infusion due to a relatively low risk of, but potential risk of recurrent cytokine release syndrome and/or neurologic toxicity. And after this, patients should be monitored monitored for prolonged cytopenias. About a quarter of the patients may develop transfusion dependent and need GCSF as needed for ongoing cytopenias and neutropenia. Because these CAR T cells, especially targeting CD19, also target healthy B cells, patients are rendered B cell aplastic, and their IgG levels should be followed and repleted if they fall below 400. Obviously, patients should be monitored for relapse, and then there's a theoretical concern for secondary malignancies, and so patients should be monitored for those. Because of the use of lymphodepleting chemotherapy, patients actually remain lymphopenic for quite some time after CAR T cell therapy, and so we continue antibiotic, both herpes and PJP prophylaxis for at least 6 months, and then at which point we start measuring their CD4 count, and when the CD4 count is over 200 is when we feel safe discontinuing these. And finally, upon relapse, patients should be biopsied whenever possible. These patients could be candidates for immunomodulatory therapies that can potentially salvage CAR T cell relapses. And for this instance, specifically for this, we would want to check PD-L1 status of the tumor and the tumor microenvironment. Their patients may be eligible for repeat CAR T cell infusions, although there's limited testing of this in lymphoma, and it's unclear if there's any role in this population. And finally, there are trials of CD20 bispecific antibodies or polatuzumab being used in the setting, which have been successful. So in summary, who should get CAR T cells for lymphoma? We know that anti-CD19 CAR T cell therapy leads to durable remission in 40% of patients with relapse and refractory aggressive B-cell non-Hodgkin lymphoma. And this led to the FDA approval in diffuse large B-cell lymphoma, high-grade B-cell lymphoma, transformed follicular lymphoma, and primary mediastinal large B-cell lymphoma in the third line and beyond. When we expand beyond a clinical trial population in the real world, we see similar response rates and similar rates of toxicity in a broader population than which would have been eligible for the clinical trials. Patients with comorbidities may do worse than patients without some of those comorbidities, but they still do better than with available treatment options. And treating centers will adapt eligibility criteria according to what they feel is safe and appropriate based on some of this real-world data. Enrolling clinical trials include new products, new combinations, and new indications and lymphoma subtypes. It's really important to get to know the eligibility criteria for commercial CAR at your referring center, as well as available CAR T cell therapy clinical trials to make appropriate and quick referrals. And of course, the relationships between referring and referral centers and oncologists are vital. This is a team effort for everyone involved to be able to get this really quite revolutionary therapy available to our patients. Thank you.